Hello and welcome to Agilon Health's Healthcare Value Week panel discussion. I'm Claire Mulhearn. I'm the Chief Communications and Public Affairs Officer at Agilon Health. We're very excited to be hosting today's panel, and I will quickly introduce our panelists and get us going. But I want to introduce Agilon Health and kind of set the stage for today's discussion. Agilon Health is a value-based care company that enables physician practices to take on full risk. That means together, we are fully accountable for the total cost and quality of care for every one of the 650 Medicare patients in our model. We partner with more than 2,400 primary care physicians across 13 states and 31 communities. Ours is a partnership model, and I think that's important. It's not an ownership model. And we help independent primary care practices, practice associations, and health systems sustain their business through value-based care. I am very proud to be joined today by four of Agilon's physician partners, Dr. Amanda Williams, who's the medical director at Physicians Group of Southeastern Ohio and Zanesville, Ohio, Dr. Frank Civitarese, who's the president at Preferred Primary Care Physicians in Pittsburgh, Pennsylvania, Dr. Mark Ambler, who's the chief of family medicine at Osto Regional Clinic in Austin, Texas, and Dr. Pamela Zelasko, who's the medical director at Answer Health in Michigan. So let's dive right into our discussion today. I'm excited to get going. As I think many of you know, 2023 was rife with policy discussions focused on healthcare cost, consolidation, and workforce challenges. As baby boomer generations ages, Medicare enrollment will continue to accelerate, and we're seeing that happen right now with our most recent AEP season, placing further pressure on costs to the government and taxpayers, and an already overburdened workforce and economic forces causing further consolidation. Agilon Health and our world-class physician partners believe that full risk, accountable care models can help address these challenges, both now and in the future. Yet, we know the term value-based care often means different things to different people. So I'd really like to kick off today's discussion with starting with defining what do we mean when we say value-based care. I'm going to ask Dr. Williams and Dr. Ambler to kind of kick off our panel today. So could you tell us what value-based care means to you? Why do you think, what do you think it means to your patients? And maybe Dr. Williams, we can start with you.
Okay. Thank you, Claire. Yes, so I'm Mandy Williams. I am a family physician and geriatrician practicing in Zanesville, Ohio. I am the medical director for Physicians Group of Southeastern Ohio, which consists of 72 independent primary care providers and now one specialist. And we have had a relationship with Agilon now since 2019. Can't believe that. So value-based care in simplest terms to me means providing high quality care in a cost-effective way, which in turn provides a higher quality of life, not only for patients, but also for providers. You know, as a provider, when you're on that fee-for-service hamster wheel, it can lead to burnout for all. And there's that statistic around women physicians that always really strikes me. And it's that 40% of women physicians go part-time or leave medicine altogether within 6 years of completion of their residency. Maybe even more disturbing is suicide amongst doctors. 300 to 400 doctors commit suicide every year in the US. That's more than my entire medical school, all 4 classes combined. And this really hit home for me in the last year. I lost a physician friend. So I believe we can do better, and value-based care is where that's at because it offers greater flexibility to deliver the right care at the right time and can contribute to a greater sense of purpose for our providers. As flexibility in real time as a mom, that means I can pick up my kids from school. And it's because I'm not inundated with the pressure to see more and more patients like we see with the fee-for-service model. As far as the patients go, anecdotally, they love it. I just mentioned earlier, I saw a new patient today, and he was just so struck by our conversation. He was like, wow, when I see doctors, it usually feels like they're herding cattle, and you're actually sitting here and listening to me and treating me like a human being. And sadly, we hear that a lot with the value-based care model. And I do have some evidence to back that up. Last year, we participated in the ACO REACH, and our patient survey results showed that we scored above average in all 8 out of 8 domains. And for 6 out of 8, we were in the 80th and 90th percentile.
Wow, that's amazing. Thank you so much for sharing that, Dr. Williams. And I do want to comment on the fact that you brought up the comment on, kind of women physicians. Dr. Williams is one of our founding members of our Women's Physician Leadership Council that is really focusing on raising up women physicians within value-based care and overall. And so I think that's a critical topic that hopefully we'll touch upon again today. But Dr. Ambler, maybe you can add on to what Dr. Williams was speaking about in terms of what does value-based care mean to you? Again, everyone thinks about this a little bit differently, but I think we'll probably hear a common theme in terms of the impact that it's having on the patient and the provider. So would love to hear your thoughts.
Yeah, thanks. I'm Mark Ambler. I'm a family medicine doctor with Austin Regional Clinic in Austin, Texas. I've been there since 2001. We're a multi-specialty independent physician-owned group started in 1980 by a family medicine doctor. We have about 400 providers, and about 2/3 of those are primary care, and about 1/3 of those are specialty. We've been with Agilon Health since 2018. And, that's kind of when I got involved in this value-based care business, and it's been a learning experience and very interesting. I really, think that providers and physicians and patients are looking for something other than the hamster wheel that Dr. Williams mentioned, where you're just seeing patient after patient and you kind of lose sight of the true overall picture of the patient. I think with the value-based system, what's different is you can do things that are not reimbursed in a fee-for-service world. So you can spend the time to call specialists and coordinate care better. You can spend time to take care of a panel where I'm going to see patients that haven't been in. Previously, just kind of worried about who was on my schedule for the day. But now I can say, well, I haven't seen Mrs. Jones for a while. Maybe we need to get her in and figure out what's going on. We have data that comes, a lot of that from Agilon, to figure out who's been in the hospital, who's been in the ER, things that were difficult to access previously. And I think coordinating that care is really what is much of what value-based care entails.
Well, thank you both. I heard key themes out of that: the coordination of care, really putting that patient first, the data component that is really allowing you to identify those patients that need that extra touch. That maybe wouldn't normally get that operating in the fee-for-service, where it's about really focusing on the volume of services that you're delivering to the patient that you have, and that kind of focus on the whole panel. We're going to take a deeper dive, and this was really helpful context to kind of set up the next part of our discussion. One of the unique things about our partnership model is that we are almost exclusively focused on full risk programs in Medicare. So ACO REACH, which Dr. Williams touched on, and subcapitated risk arrangements in Medicare Advantage. So when we say, just like when we say, value-based care, people have different definitions. When we say full risk, there are different definitions out there. So when we're talking about risk arrangements and what we're talking about today, what we're talking about is risk arrangements that feature 100% upside and downside risk for the total cost and quality of care for Medicare Parts A and B. And I think that that's really important because there's different definitions out there. For those entrenched in the healthcare and health policy space, there have been kind of conceptual understanding of full risk, but that's often where that understanding ends. And so we do want to hear from Dr. Civitarese and Dr. Zelasko in terms of, can you describe what full risk really looks like from a business and operational perspective? Because when you get on the ground, this is where the rubber hits the road and really how this needs to operate in the practice. What have you learned? How are you doing things differently, to really invest and transform your practice as you think about moving to that full risk value-based care form of your practice? So Dr. Civitarese, maybe we can start with you, and then Dr. Zelasko, if you want to add to what Dr. Civitarese said.
Thanks, Claire. We've been with Agilon Health since 2019. I'm a practicing family physician and also a geriatrician. I'm president of independent 50 physician primary care group here in Western Pennsylvania. We entered risk contracting in 2019 and transition from a fee-for-service model to value-based care, I think conceptually, the way we see this is that we can no longer deliver care in a siloed fashion. And I think the American healthcare system right now is a siloed healthcare delivery system. This arrangement permits us to embed ourselves as primary care physicians in the patient's care, the full spectrum of the care that they're being given. And as a result, we're able to impact that care. Many times over the last several years, we've become increasingly frustrated with our inability to touch these patients outside of the physician office. Sometimes I think as primary care physicians, we deluded ourselves into thinking that if in the best of circumstances, maybe we see a Medicare patient for a half hour 4 times a year, that results in 2 hours out of a year. And we deluded ourselves into thinking that we really were making an impact. The reality is the majority of care that's being delivered occurs outside the 4 walls of this office that I'm in. And as a result, in a value-based care model, we're able to, we euphemistically in Pittsburgh, we claim that we bubble wrap our patients. So in essence, we provide out-of-office services that we would never be able to provide in a fee-for-service model. And in a total risk model, we also recognize the fact that we are responsible for all the care that is delivered to this patient, irrespective of the settings. And as a primary care physician, it's rewarding to realize now that from a satisfaction standpoint, we are now impactful in the care that our patients are being given, no matter where that care is given. And as a result, we're able to ultimately improve outcomes and also improve patient satisfaction in addition to physician satisfaction. So our physicians love the model because we've now been reinserted into the middle of that patient's care, and we have an ability to impact it that we never were able to do in the fee-for-service model.
And I think that's the critical piece. I loved what you said at the end, Frank, in terms of the provider and patient satisfaction, because happy doctors make happy patients and vice versa. So Dr. Zelasko, would love to hear your thoughts on how this is kind of transpired at Answer Health, which is a different model in terms of practice setup. So if you could introduce yourself and share a little, that'd be great.
Sure, thank you. I'm Pam Zelasko. I'm a practicing family physician in Grand Rapids, Michigan. I'm in a practice with 2 physicians and 2 APPs, and our practice is part of a much larger network called Answer Health. And we're an IPA structure. We have about 180 PCPs and over 800 specialists. We are all separate TINs. We're all independent business owners. So when we took on full risk and partnership with Agilon back in 2020, we recognized that it was going to be a heavy lift, a lot of work to coordinate our efforts and really understand what value-based care means. In terms of making this decision at the practice level, I mean, you have to think about it from a business standpoint. There is cost involved. I mean, you have to figure out based on determining from data, you know, where the cost drivers are, where you need to focus your energy, what kind of care delivery solutions you need to provide for this population of patients. And you also have to develop infrastructure, which, you know, those startup costs, you know, until you are actually earning rewards from providing the care in this model, there are startup costs. So, you know, you have to be thoughtful about that. And from an operational standpoint, when I think about it, it's the patient is the keystone. They're right in the middle of it. And without patient engagement, we can't be successful. They have to understand too that part of our efforts in terms of, you know, what was mentioned already, seeing them more frequently, spending more time with them, wrapping them up in other services outside of our 4 walls. I mean, they have to be willing to accept that healthcare delivery is changing for them too. When we transitioned from fee-for-service to value-based care in my office, you know, one of the first things we did was work on our patient workflows to really ensure that we were closing gaps in care, that we were training our staff to understand, you know, who this patient panel was, and that they were going to be receiving care in a little bit different way. Also the training that went into it, not only at the practice level, but at the network level, we had hours and hours and hours of training around accurate and complete documentation and coding to really reflect the burden of illness of these patients. And all of this has driven us to a point where we really understand what these patients' needs are, because you really do have to have an operational structure that is reflective of the population that you're serving.
And I think that's a key piece that you said at the end, Pam, of, really reflecting that population that you're serving and making sure that you're understanding the burden of illness of your patients. That was just excellent. So now that we've kind of laid the groundwork in terms of how we're defining value-based care, now we know what full risk looks like on the ground. And thank you, Dr. Civitarese and Dr. Zelasko, for sharing that, and how this really kind of changes the incentive as we think about that fee-for-service visit volume hamster wheel that Dr. Williams and others talked about, to this alternative approach that really places the patient at the center of everything that we do. And I think we heard that consistently across all of our physicians here today. What we want to turn to next is kind of a discussion of, what does that really look like in terms of patient stories and impact data that we're seeing. There's numerous studies that have been out there that really illustrate value-based care and how it produces better outcomes for patients at a lower cost. An example of that is, Agilon and our physician network actually published a peer-reviewed study in palliative care recently in the Journal of Pain and Symptom Management. This survey looked at 900 patients that were treated by Agilon partner physicians and compared those to enrolled in other palliative care programs that really didn't put the primary care physician at the center of it. And what this data found is that when you have alignment between the wishes of the senior patient and their family, to have that passing at home and the outcomes the program was able to generate, and we saw 65% reduction in hospital-based deaths. Seniors were able to spend an additional 5 days at home at the end of life. And I think we've all had a loved one pass, and being able to be with them instead of them sitting in a hospital bed is so important. And with that, we were able to see that 33% reduction in a total cost of care for those patients in this study. But for those of us that aren't academics, what we do want to know is that hear from each of you in terms of what does this really mean for your practice? Data that you've seen that has really shown that these models are working, these full risk models are working, and any patient stories that you can share that really bring that to life. Maybe Dr. Civitarese, we can start with you because I know you were one of the practices that participated in this palliative care study, but I've heard you say many incredible patient stories over the years that have really shown impact, and maybe we can start with you and just have an open dialogue across the board.
Sure, Claire. We've experienced in our practice, as evidenced by the data that were published in the paper, that there's no question that if you focus your efforts in the Medicare population on what we would term advanced care planning, and that advanced care planning can range from just a discussion all the way to palliative care and ultimately to hospice. But the discussions that need to be had with these patients are extremely important, irrespective of their age. It's always critical to make sure that we as physicians are delivering the care that a patient and family expect. And we had a particular patient who was elderly. He was in our chronic care management program and also in our advanced care planning program. And he was declining, and he was talking to our social worker who met with him regularly, and he said, what I'd really like to do before I pass is I would love to go on a family vacation that in Pittsburgh, everybody ends up in the Outer Banks for some reason. I don't know how that all happened.
Beautiful there.
Yeah. So everybody vacations in the Outer Banks. And so historically, this patient had taken his entire extended family to the Outer Banks on a yearly basis, and he had been unable to do it for years because of his health condition. And so with the aid of our care manager and our social worker and our dietitian, we were able to arrange for oxygen to be delivered and for transportation, and for him to be able to spend a week with his extended family in Nags Head, North Carolina, which brought back many great memories for him and the family. And when he returned, he actually, I understand this is a little hyperbolic, but he was in tears, and he actually called our social worker and our RN care manager to thank them for all the efforts they made to make this vacation a reality. And in the end, he ended up in our advanced care planning program. And our advanced care planning program has resulted in tremendous results from a standpoint that patients and families are satisfied in the care that they were delivered at the end of their life. We've been able to increase our hospice length of stay exponentially. And there's nothing better than a patient being able to stay at home and to receive the services that are necessary in their end of life journey. And so from a physician and a patient standpoint, we've had great satisfaction with the advanced care planning model, and it's now become a keystone of what we try to do with all of our patients, whether it be enrolling them in our care management program or availing them of our social service department, our nutritionist, and our PharmD. None of these services would be available in a fee-for-service model. We've been able to create these programs that, in essence, as I said before, bubble wrap these patients and provide them the necessary means to live the fullest life that they can.
Thank you, Dr. Civitarese. I open it up to the floor. Dr. Williams, do you want to go next? And please feel free. I'd love for you guys to just have a dialogue. You're the experts here.
Yeah, sure. I'd love to. And that was a great story too. So I'm going to start with data. So for quality improvements from 2020 to 2023, our annual wellness visits increased from 79% in 2020 to 94% in 2023. Our HEDIS quality star ratings increased from 3.4 stars in 2020 to being on track to 4.3 stars in 2023. For our high-risk patient care, our overall high-risk claims expense improved by 18% since 2021, and our inpatient utilization decreased by 16% since 2021. Our high-risk PCP touchpoints, so seeing those high-risk patients more frequently, increased to an average of 5.4 visits per high-risk patient, which was a 10% improvement from 2022. I'd also like to share a patient story, if that's okay, about a patient that is near and dear to my heart. He's a 92-year-old male, and he's 92, so he's got a lot of chronic comorbidities, heart failure, CABG, bladder cancer, and he unfortunately was experiencing issues with low back pain, was pursuing that. Amidst that, he had an incidental finding of a AAA, so abdominal aortic aneurysm, of which he was starting to pursue that. Amidst all of that, he experienced a massive pulmonary embolism. He was hospitalized, and after he was hospitalized, because I'm in this value-based care model and now have the time to sit down with patients and do a little bit of advanced care planning like Frank was just talking about. And, I just asked him, what would your ideal end of life look like? What are your goals of care? And you know what? He didn't want to pursue that AAA repair. He just wanted to be able to breathe, and he wanted to die at home. So I'm happy to report that he is currently actually in a condo in Florida because he's a snowbirder that overlooks the ocean, and he is comfortable.
Thank you for sharing that, Dr. Williams. I think what you and Dr. Civitarese shared is exactly what we're trying to do here, particularly for those higher risk patients at their end of life, is, as we talked about, really providing them their wishes versus spending time in the hospital, potentially having higher costs for their family, for the health system, et cetera. Dr. Ambler, Dr. Zelasko, you had shared earlier some incredible stories just around, particularly around higher risk areas like kidney health and diabetes. Would love to hear you kind of speak to that and be able to share how this is really coming to life for your patients and the value-based model that you're operating.
Sure. I have a patient also near and dear to my heart. She's an 81-year-old who I've taken care of, I think, pretty much since the beginning of my career. And it's been, kind of hard to watch her age. And she has developed, diabetes, hypertension. She's got pulmonary hypertension, chronic back pain. And 2 years ago, she had a significant decline in her kidney function. So, and it was a result of her diabetes not being as well controlled as it should have been. And so we enrolled her in a kidney health program, which is home-based. And when she was enrolled, her GFR, her filtration rate was 34. She's currently at 26, but she's still not on dialysis, which is the end game. The end goal is to try to keep them off dialysis. Due to her back pain and just everything that's going on with her, she has a hard time getting out of her condo, coming to the office. So in November of last year, I had the opportunity, because I was very curious about what actually happened in the home. I was able to go to her home with the care manager from the kidney health program and sit in on a visit. And it was a little humorous. When I walked in, she thought I was coming to give her bad news. And I said, no, I'm not really here to see you. I said, I am here to see you, but I'm really here to see what, this young lady is going to do. And it was very impressive, because just the level of education and even the level of patient engagement. My patient pulled out a notebook. She was recording her weights. She was recording her blood pressure. She was recording her blood sugars in anticipation of knowing that this care manager who had been seeing her for a year and a half was coming in for a visit. I was very pleased with the quality of care that was being delivered. The other thing that happened, and you touched on advanced care planning, that was a topic that I had tried to bring up with her in the office multiple times. She was very stoic. She said, I don't want to talk about it. Okay. Her daughter happened to be with her at this visit, and the care manager had the wherewithal and the social skills to be able to say, can we talk about, your goals? So we kind of eased into this conversation, and we were able to actually open the door on a conversation about, talking about what her end of life goals would be if she did progress, if her kidneys did get worse and so forth. So, in all of my career, I've never had the ability to really feel this good about the level of quality of care that was delivered. And she's doing very well. She's been stable. She's not been in the hospital. She's not been in the ER. I think it's a win-win.
Yeah, that's great. And we need to be able to meet patients where they're at. And I think that the ability for you to be able to bring that type of care into the patient's home if they are not able to get to the office is incredibly important. Dr. Ambler, would love to hear from you. I know you had shared earlier just kind of a story around some of your diabetes patients. Oh, I think you're on.
We've had a focus around diabetics, and have been able to reduce our percentage of uncontrolled diabetics from 25% to 15%, and our diabetic eye exam screening from 65% to 80%. And this is a lot of just, focusing, building programs based around this. I have a patient I've been seeing for probably almost 20 years, and he's had diabetes and hasn't, necessarily taken it as seriously as maybe he could have over the years, and unfortunately developed a foot ulcer and an amputation about 2 years ago. And that got his attention. So, we really involved a lot of people. We have a nurse navigator that's in my office that will see the patient with me. They will call the patient on a frequent basis, depending on what the patient is needing, seeing how their sugar is doing, how their blood pressure is doing, have they been able to follow up with their specialist. But we also have a home visit program where we have someone that can go out to the home and check on the patient and see how they're doing. One of the things that really became apparent is he just wasn't able to take care of himself, and he was somewhat estranged from his daughter. It was kind of a strained relationship. But really, with this home visit program, the provider engaged the family and really worked out well for the patient. So he's living with his daughter now. He's really taking good care of himself. His hemoglobin A1C, which was wildly uncontrolled at about 12 a couple of years ago, is now 6.9. He's using his insulin regularly. He's really taking care of his other foot. He's been walking with a prosthetic. He hasn't been in the hospital in the last year at all. So these are the kinds of things that we can do for patients to really impact their lives, as long as we have the resources that we need to be able to do that.
And I think the key point you said there is the resources, the time. I think the key theme that we've been hearing through this is that when you're focused on really just getting patients in and out, that you're not going to be able to provide that quality of care and those wraparound services. I love, Dr. Civitarese, how you talk about the bubble wrapping. I think that all you guys have been sharing here today is that ability that we have through value-based care and this full risk model where you're totally accountable for the total cost and quality of care for that patient, that you're able to bubble wrap them and really bring the quality of care that is needed for our aging population. I would be remiss if I didn't end our discussion today really focusing on, considering all that we've discussed, what does this mean from a policy perspective? Being able to deliver full risk and value-based care through Medicare is contingent on us being able to have these incredible programs. I would love to hear from each of you as practicing physicians that are taking care of patients in this model day in and day out. What would be that one thing that you would want to share and hope that policymakers would know and consider as they discern the future of Medicare policy? So maybe Dr. Ambler, we can start with you. We'll kind of go in the reverse. If you could share that one thing that you want them to take home, and we'll just kind of go around the group here.
Yeah, as mentioned previously by Dr. Zelasko, it's we're kind of straddling different systems at this point, where half our population may be in a fee-for-service and half of our population may be in a value-based care model. And really, we need the fee-for-service funding to be able to kind of keep us afloat, but we also need that stability that this is going to be something that's a long-term plan that's sustainable, because really these, as people have mentioned, these programs require a lot of investment, a lot of time and money to do them correctly. And if you spend 2 years building a program that really is going to work, but then ultimately doesn't get reimbursed 3 years from now, you just can't survive that way. So I think everybody just kind of wants that long-term stability as much as anything else.
Dr. Zelasko?
I would ask them to promote innovative payment and care delivery models that really truly support us in value-based care.
Dr. Williams?
Yeah, I would just say our current healthcare system's a bit broken. We have an unsustainable cost structure of increased healthcare spending coupled with relatively low health outcomes. I think with purely fee-for-service, our patients are disheartened, our providers are disheartened. I think of my friend. And I really think that problem is that misaligned incentives with fee-for-service, and the solution is full risk value-based care. So let's keep heading in that direction.
And Dr. Civitarese?
Claire, I guess I think all of us would be safe to say that we've lived in the fee-for-service model and we've lived in a value-based care model, and we and our patients prefer a value-based care model. I think it's more rewarding. It provides better outcomes, and ultimately, it's more cost efficient. In Pittsburgh, we've been in risk models in various iterations for now 10 years. So initially, for 3 years, we were on a track 1 ACO, then we were on a track 1 plus ACO, and then we partnered with Agilon. And I have to say that we collectively, as primary care physicians, are at the vanguard of risk contracting. And if you look at the model that currently exists in the country that Mandy alluded to, it's very disheartening to realize that we are increasingly on a yearly basis adding to the cost of healthcare without necessarily improving outcomes. We're now at 18 or 19% of GDP committed to healthcare. The reality is that I don't think there's an end in sight. I don't think anybody has solved the equation of how to bend the cost curve. And I understand I'm prejudiced in this, but I believe that value-based care in the primary care setting is the only way to do this. And so if I were speaking to policymakers, I would say the ACOs and the models that CMS have created are at the vanguard of healthcare. And if we can't do it, nobody can. And I'm convinced of that. So I would strongly advise or hope that CMS would continue to create and be creative in the models that they offer to physicians in general, but in particular primary care physicians, because we sit at the center of this model, and we believe that we have the ability to impact care across the spectrum. There isn't another specialty that can do that. And I think if CMS places its trust in the primary care model and provides support in risk contracting, that we believe we can actually transform care that's being delivered in this country from a fee-for-service model to all of the stories that you just heard in a value-based care system.
Well, thank you, Civitarese, Dr. Civitarese, for really bringing that home. I think you hit the nail on the head in terms of really being able to transform healthcare and the need for value-based care and full risk models to be able to do that. I want to thank all of you for being here today and sharing your wisdom, the incredible impact that you are having for patients within your practice, and what that means for providers in terms of also improving their sustainability and quality, in terms of how they are able to deliver medicine, be the doctors they were trained to be. So thank you so much for joining us today. And we really appreciate everyone listening in. And congrats to an incredible Healthcare Value Week. So thank you all.